So, yeah, we're going to jump into some of the talks directly addressing some of this exciting information about the cardiometabolic pathways and the treatment targets. And we'll start by inviting up Dr. Rodica Busui, who's a wonderful colleague of mine in the Diabetic Foot Consortium, but who is a world-renowned leader in clinical trials in diabetes. She's the head of the Endocrinology, Diabetes and Nutrition division at Oregon Health and Sciences University. She's also a past president of the American Diabetes Association and a true leader in bringing evidence-based care into diabetes. Rodica, thank you for joining us.
Well, thank you so much, Mike. This is a very nice introduction. And once again, I'd just like to express my enthusiasm of being here. Thank you and Manesh and Isabel and the entire Vascular Cure community for working on this important topic. And as I mentioned earlier, I am a diabetologist. I am a physician scientist and a clinician that had spent her career in helping people with diabetes to have a better life. And I think that that's why I would like to spin the task that I was given this morning to talk about new metabolic pathways and new therapies from a scientific perspective, but spin it specifically on diabetes. And that reason I like to do that is because, as I mentioned, diabetes is the quintessential example of a true vascular disease, vascular injury. And we've learned that it's not a simple glucose disease, it's actually much more. I put some of my disclosures here, and I just like to say that I've been thinking about this task that was given to me, and I thought that I will start very briefly understanding the vascular biology architecture that is happening in diabetes, and what we have learned over the years, how to integrate more traditional mechanism with these emerging metabolic and inflammatory pathways, and see how we can actually leverage this knowledge to understand new therapies, to understand how we should apply precision medicine to improve cardiovascular, kidney, and peripheral arterial disease outcomes. Now, Mike had put a version of these numbers, but I think that unfortunately the reality is even more grim. These are the most recent numbers. 600 million worldwide. We have actually 41 million in the US as we speak with diagnosed diabetes, and about 106 million with pre-diabetes. So that's just to put in perspective where we stand, and all these people will have a certain vascular involvement, and the costs are non-sustainable. Mike and Manesh has already mentioned that this is diabetes-related cost, because we have to remember that, yes, vascular disease is a very important component of all these challenges that people with diabetes face, but it's more than just vascular disease when we think about healthcare of diabetes, including technology, including the psychosocial component, which are not trivial. So we have made a remarkable progress. We've learned how to treat glycemia, and we've learned that treating glycemia to some targets will prevent more severe disease. We have made remarkable progress in lipid and hypertension management. And yet, people with diabetes continue to experience an excess risk of atherosclerotic cardiovascular disease, an excess MI, stroke, PAD, amputation, CKD. And what is becoming increasingly clear is that these complications are not isolated. PAD doesn't happen just because of PAD. All these complications actually work in a unifying, unfortunately, approach. And what is very important is that diabetes accelerates this vascular injury, and many of these injuries are present early in the course of the disease when we currently cannot identify them. We don't have that tool. And that may explain perhaps this residual risk that has been already mentioned by both Mike and Manesh. So you know very well this, biology of plaque. And that has been known for years. But what I like to highlight in this slide is that in diabetes, this journey from a healthy endothelium to endothelial dysfunction, more foam cell generation, and ultimately thrombosis, it's further amplified. There is much more inflammation, much more oxidative stress, much more lipotoxicity in diabetes because of this convergence of mechanisms that include hyperglycemia, insulin resistance, advanced glycation. So that is why this system biology framework highlighted in this slide help us understand why targeting a single pathway is no longer sufficient. We need to have therapies that target multiple pathways, and perhaps what we have been able to develop with this newer medicine, as I'll show, is that we are now accomplishing exactly that. The cardio-kidney metabolic interconnected axis has been already mentioned, and I don't want to spend too much time that. It's true. These organs do not, this tissue injury, it's not working as a passive component. So adipocytes are not passive storage lipids. They are, in fact, endocrine organs. We've now learned they produce hormone, and most importantly, they generate these inflammatory pathways. Kidney dysfunction amplifies cardiovascular disease, heart failure amplifies kidney disease and PAD. So rather than separate disease, we recognize that this is unified, axis here. But what's also very important is that while we do understand that there are some special centers around the country, we have this cardiometabolic kidney center. The reality is how many of these 41 million of people can even have access to that center. So just creating this center, it's not the solution. Yes, it's a model in which we can test new therapy and new strategies, but our work is much higher because we need somehow to translate that so the entire community has access to that. The other important knowledge that we have gained, and I have to say that, I'm a diabetologist and I was educated in medical school that glucose is the reason. And yes, it's true. Hyperglycemia is at the center of multiple of these mechanisms, whether it's polyol or it's PKC or it's mitochondrial reactive oxygen species generations. But what is very important is that these pathways do converge into downstream consequences, and while glucose toxicity is important, it's not the only target. If we think about how we can take each of the information that we have learned over the years, transitioning from vascular disease, from this isolated risk factor, how we can actually look at, for instance, the tubule, the adipocyte, the immune cells, and then, select and design a new medication. And I think that we are quite successful if we think about these most recent classes of medications that have been already mentioned, the GLP-1 receptor agonist and the SGLT2 inhibitors. What's important, the reason that we are finally seeing an impact is because they do not act on a single target. They were developed as glucose-lowering therapy, but the reality is that their biology is so much more complex. And I'm just giving you the SGLT2 and GLP-1 because obviously they have been the first classes that have truly made an impact in reducing cardio-kidney outcome. Take the SGLT2 inhibitors, right? From this effect on the tubule in increasing natriuresis and glycosuria, they actually have been able to act on a multi-pathway mediated effect and then translate it in these benefits. And these benefits have been highlighted in these multiple clinical trials, starting with EMPA that was the first one that showed a significant cardiovascular risk reduction, heart failure reduction, sudden death, but then being replicated across these multiple other cardiovascular outcome trials, demonstrating similar benefits despite slightly different study design and patient populations. Similarly, the GLP-1 receptor agonist, and Mike and Manesh have already shown a variation of this slide, right? They are no longer glucose-lowering drugs because they act on the entire vascular arterial tree, right? And there are several mechanisms, but perhaps at least for GLP-1 receptor agonist, as we have learned now, because it's consistent across multiple trials, is this unifying effect on reducing systemic inflammation, vascular inflammation. And that has been, again, translated in a variety of GLP-1 receptor agonist study, initially with short-acting agonists, like demonstrated in these slides, and more recently with the longer-acting that have further demonstrated the benefit with SOL trial, highlighting that, in fact, an oral GLP-1 receptor agonist has the same efficacy in cardiovascular risk reduction and highlighting additional benefits on heart failure and PAD, which were further complemented by the STRIDE trial that I know that Mark will talk in detail, as well as the FLOW that clearly demonstrated their effectiveness on CKD outcome, which I suspect that Kathy will go in more detail. So where are we? What is the provocative questions for the future? Is this residual risk? Because we know that even in this landmark trial and new discoveries that we are making an effect, the residual risk exists. And this is where the opportunity resides. Well, we have talked about some of the inflammation, but there are this new class of medications targeting the inflammasome, the mitochondria, the platelet activation at much higher level, the liver, and then, of course, the sRNAs and endogenetic components. And what is particularly exciting, and I'm so happy to be here to see that concept in this room, is that we are now moving to a multimodal targeting of these interconnected biological pathways, and we are now in a position to do so. Because to truly make an impact, first of all, we'll have to identify this vascular injury with sensitive and specific tools much earlier in their course of the disease, and then to understand this multiple network modulation. So the questions that I came up with for this audience, because I was asked to think about some question, is what are the most actionable early metabolic pathways that we should concentrate? What define vascular resilience biomarkers? Because that's very important to understand that even with this, tsunami of vascular injury, there are still patients that have a significant resistance. I was talking this morning, and we do have patients with diabetes that lived for 70 years. And at the time that they were diagnosed, they were bluntly told, I have patients who told me when I was diagnosed, I was told that I will never have kids, that I will not live beyond 30, and I will die being hooked on a dialysis machine. And we have demonstrated that's actually not happening anymore. But that's also an innate resilience to this vascular injury that I think it's also a key component that we need to concentrate on to better understand how to target in a precision approach. Can this metabolic memory, not in the positive, because we have identified that treating early glucose in type 1 diabetes, in fact, prevented complication for up to 20 years. And we call it metabolic memory, but there is another type of metabolic memory. It's the metabolic memory of the injury. Can we actually reverse that much earlier in the course of the disease? And I think that we can. I mean, obviously, we are in a big data times right now. We have our basic scientists that are working side by side with us, trying to identify these multi-omic pathways. And then we have, of course, our partner in industry. But we are in the AI and understanding the entire complexity of which vascular target is most affected in a given patient, so we can actually give the right treatment to the right patient at the right time. I think this is the key that we can address. And then AI, it's important, I completely agree. And there is a lot of misinformation, but we have a power here too. I mean, we are the societies, we are the scientists that we are generating the evidence. So we need to force AI to actually take our evidence and put it there for patients so that this misinformation can be dispelled. And I like to end with this slide. Yes, we practice, unfortunately, in a siloed healthcare system. But I like to say that patients with diabetes, people with diabetes and prediabetes are not. So diabetes is a system-level vascular disease, and patients are a whole. They are not components, they are not pieces. And it is our role to bring the science as a whole, but also to make sure that we partner and create the best system delivery of care for these patients and make it easier and understandable and trustworthy for them to participate in their care. So that is my talk, and those are my points, and thank you so much for your attention. Question at the end or after?
We'll do it at the end. Thank you, Rodica. That, as expected, was outstanding and highly provocative, and lots of questions already in my mind. But we'll do this at the end of the session. So next, I'd like to ask Kathy Tuttle, who's here with us from Providence Northwest Health. She's the executive director for research. She's a nephrologist and a professor of medicine and a clinical trialist who's led also in some of these landmark trials of renal disease and their cardiovascular relationships. Kathy, thank you for joining us. We're looking forward to your talk.
Well, thank you very much for the kind invitation and the opportunity to join you for these really important discussions today. And I'm going to pivot us a little bit. First, my disclosures, as usual, all related to treatments across the CKM spectrum. And I'm going to take you into the world of chronic kidney disease. So this is a public health crisis. The Global Burden of Disease study by The Lancet just updated. It was published simultaneously with ASN Kidney Week in November 2025. We now have the dubious distinction of 800 million people worldwide living with kidney disease. The mortality related to this disease has also increased progressively, and we'll talk about the intersectionality with cardiovascular disease, but up more than 40% over the last 30 years. This is 1 in 10 people in the general population. I'll show you data from the US, but it's actually more like 1 in 7. Also, according to the Global Burden of Disease study, it's progressively rising in rank in leading cause of death worldwide. 19th in 2013, by 2025, 9th. And if we don't change what's happening, it'll be the 5th leading cause of death in the world by 2040. Here is data from the US, 40 million people, this is 2023 data. 147,000 attributable deaths, but this is really undercounting because these are largely vascular deaths. And I will make the case that many are not attributed to this driving cause. And so I think it's very timely that we're talking about really what's going on behind the scenes with this patient population. So again, Rodica gave us a great overview of diabetes, and I'm also going to drop you into diabetes because it's the leading cause of kidney disease worldwide. Oops, excuse me. She gave you IDF estimates. These are 2021 numbers, nearly 540 million. They, like the Global Burden of Disease study, do future projections, and they've projected that by 2050 we'll have 1 billion people on the planet with diabetes. So while diabetes prevention remains the holy grail, it's sad to see how poorly it is translated into communities. And I think the reality that we need to face is that for the foreseeable future, and even if you're young, for your lifetimes, there are going to be more people on the planet living with diabetes. That means living with diabetes complications. So still 4 in 10 with type 2 and 3 in 10 with type 1, which is also a growing population, develop so-called diabetic kidney disease, or kidney disease squarely attributable to the presence of diabetes. That makes it responsible for half of all CKD worldwide, so 400 million cases. And while in nephrology we've had this tunnel vision about progression to kidney failure, this is really a ragtag survivor band of just 10%. And that's because of the enormous competing risk of death. There are two major causes: cardiovascular disease, which we're talking about a lot here, but also the next leading cause of death is infection. I'm bringing this up because they're now both modifiable causes of death. And to drop in a little deeper, I wanted to think about peripheral arterial disease for this group of people. So this is the latest data from the US Renal Data System. It's a registry kept by our government about people who enter the end-stage renal disease program. And you'll see that peripheral arterial disease occurs in about 30%, but if you have diabetes, as Rodica pointed out, it's much more likely. But note that while we focus commonly on coronary disease and heart failure, very important complications, PAD is actually just as common. And if we look at, this is also data from USRDS, but looking at outcomes, what happens to people with PAD? Well, like you've heard, it doesn't occur in isolation. It often occurs with vascular disease in other territories, coronary disease, history of stroke. And this is just color coding those different combinations. But if you look at the dialysis population, of course, mortality, frankly, is the most common adverse outcome. But of all the CV events, actually major adverse limb events are even more common than acute myocardial infarction or stroke. And this is data just published 2 weeks ago now from the United Kingdom, looking at what happens to people who initiate dialysis there. And this is amputation, so now hard outcomes, right? So if people have diabetic kidney disease, 10%, if they make it 3 years, will have an amputation. Comorbid diabetes, which means having diabetes with another primary kidney disease, is also much worse than not, but diabetic kidney disease, clearly the worst. And note the mortality, 40% at 1 year. So you have to make it to even get to the amputation outcome. And this is another study also done by the vascular surgery community, looking at the risk of amputation in PAD populations by GFR. And you can see that progressively lower GFR progressively increases risk of amputation, at least in this meta-analysis, because the numbers are relatively small of studies that have separated people by these criteria. But this is a study that we did from the BEST CLI trial, looking at the relationship between GFR and outcomes. So, of course, here's the graphical abstract. Again, 1 year survival, you could say mortality, 30% if somebody is on dialysis, 3 year survival, just 43%. And in fact, the median survival of a person on dialysis with diabetes is still just 2 years, worse than almost any of the chronic diseases that we fear. And even if you look at the best CLI outcomes of open versus endovascular revascularization for critical limb-threatening ischemia, you see that there's an inflection point, and actually even at a GFR of 60, the benefit of the intervention is essentially extinguished. You see those confidence intervals overlapping, and then also note that once GFR drops less than 30, the risk of amputation or death basically escalates irrespective of what treatment you get. The other thing that, and I'm going to bring this up in my questions at the end, that has not been discussed as much, but one of the things that we did find in this analysis is lack of taking an antiplatelet agent, and specifically in the subgroup with GFR less than 30, was associated with a much higher risk of a limb outcome. And this was significant by interaction terms among subgroups. So again, we have therapeutic inertia, meaning people with low GFR, this is called renalism by my good friend Glenn Chertow, are less likely to get treatments that actually benefit people. And you could see that the outcomes then are appropriately or as expectedly worse. So what can we do about it? Now let's get hopeful. So you already heard about GLP-1s. I'm not going to recap this song and verse because we're going to have a lot of discussion about this, but I want to dial into what it means for people with kidney disease. So remember, these drugs came to us through the CVOTs. These were trials mandated by the US Food and Drug Administration in 2008. It was after the so-called rosiglitazone debacle where the agent had been put on the market for glucose lowering in type 2 diabetes, but within the first year there were multiple reports to the agency of major adverse cardiovascular events, and there had been a signal about glucose-lowering agents and cardiovascular risk for decades, going back to the sulfonylurea. So they took action and said that if a new drug was approved for glucose lowering, the sponsor would have to do a post-market approval safety study to maintain their market position. So obviously, this has been the gift that keeps on giving. Not only were they safe, they were highly effective for the diseases that you focus on so much in this group, atherosclerosis in particular. And also, again, let's call out the importance of survival. 2 agents, liraglutide and leader and semaglutide Pioneer 6 showed a cardiovascular death benefit. But some of us who'd been working in the field and who were involved said that there was good rationale that these may be kidney protective as well. And out of these cardiovascular trials, we found that onset of macroalbuminuria, which is the earliest sign of kidney disease and type 2 diabetes, and GFR decline, even in very late stage CKD, was abrogated. And the benefits on both kidney and cardiovascular outcomes persisted even in our highest risk group who had pre-existing kidney disease. So this was a very brief USA Today version of the rationale for the FLOW trial. It is the one and only dedicated kidney outcomes trial with GLP-1 receptor agonist. This is just the teaser showing you the hazard ratio and the primary outcome, but I'm going to talk about these tick boxes because this is for hierarchical testing. This means after you test the primary outcome, you can test so-called confirmatory secondary outcomes, which are defensible both methodologically and from a regulatory perspective will inform the label of the trial. And we were very proud that, as far as I know, FLOW is the only one of either of any of the SGLT2 or GLP-1 trials to make it all the way down the testing hierarchy to all-cause mortality. So, just to tell you that I'm not going to go through how we risk stratify people, but remember there are 2 measures, GFR and albuminuria, both count. If you end up in a red or hot red box, you are in a high or very high risk category, and this is not only risk of losing kidney function, kidney failure, but CVD events and death. So here's our hierarchical testing. So we started with our kidney outcome, then GFR slope, MACE, and all-cause mortality. And because this is a fast talk, I'm just going to tell you that even though I'm not going to have time to show you all this, the reduction in all-cause mortality was 20%. And this is on a background of 1 in 6 people dying in a median of 3.4 years. High mortality rate, large benefit. So here's the primary kidney outcome. And again, just look at the absolute event rates. This trial was stopped early for overwhelming efficacy, so we went only 3.4 years. 1 in 4 people had a primary outcome event. Yet it was reduced significantly because we stopped early. We had to spend alpha, which means lowering the p-value for significance to less than 0.03 to reduce the risk of a false positive trial. We met that bar handily. And then we want to look at MACE outcomes, especially for this group. Again, I want to point out the very high absolute event rate. I believe this is about twice as high as you typically see in a population selected for atherosclerosis. I think only SELECT beat this at about 15%. So I guess if you want to do a CVOT, you ought to pick CKD patients. Here is the effect on MACE, looks exactly like what you see in the CVOTs. And then what I want to pop up here for you, this was an exploratory outcome, so in true New England Journal form, we cannot test this statistically, but look at the relative risk reduction. Again, the numbers are small, but a hazard ratio of 0.56 on major adverse limb events. So sort of giving us a signal that maybe in this high-risk group of people who lose their legs all too often that there might be something that can be done about it. So again, we've talked about GLP-1 receptors. I'm going to give you now the last little bit, which is a mechanistic bit. So yes, there are GLP-1 receptors throughout the body. Again, I'm going a little nephrocentric, but here is immunohistochemistry staining for the receptor, which is found in the preglomerular vasculature, specifically in the vascular smooth muscle cells, renin-producing cells, interestingly enough, and a little bit in proximal tubule cells. So this is work from my laboratory and others, but I want to give this to you as the prelude for what we learned in the mechanistic study called REMODEL. So in multiple models, both type 1 and type 2 diabetes with different GLP-1 agents, this is a cartoon version of kidney histology, the glomerulus, tubulointerstitium. The glomerulus is very disrupted. Podocytes are falling off the glomerular basement membrane. It's thickened, mesangial expansion. This is the scar that we see, Kimmel-Steele-Wilson nodules for those of you who are diabetes aficionados. And then in the periglomerular region, we see a profound inflammatory infiltrate, particularly with immune invaders, macrophages, and T lymphocytes. And with GLP-1 treatment across these models, very consistently, we saw repair of the glomerular filtration barrier and a reduction in periglomerular inflammation. What we do know, both at the protein, and I will show you a little bit, well, I guess I won't show you, I'll give you the USA Today version of the transcriptome level in human biopsies, is we can find GLP-1 receptors in both vascular smooth muscle cells and proximal tubular cells, but like you said, not on endothelial cells. Also abundantly on macrophages and T lymphocytes, and when these agents engage the receptor, on multiple cell types through activation of certain signal pathways, particularly CAMP, cyclic AMP, mediated pathways, we see reduction in upregulation, for example, of the NF-kappa B cascade of inflammation and fibrosis factors. We see inhibition of NADPH oxidase and upregulation of heme oxygenase, which reduces intracellular stress. So enter the REMODEL trial. This was the companion mechanistic trial to FLOW. I'm not going to read you the patient characteristics, chapter and verse, but suffice it to say, they mirrored the FLOW population. But in addition to having randomized treatment for 1 year, they had functional magnetic resonance imaging, and in a subset, 1/3 of the patients had kidney biopsy at baseline and after 1 year of randomized treatment. So first off, on the functional imaging, again, I'm just going to give you the highlights. There was a profound reduction in perirenal and intrarenal fat. Now, this was not a weight loss study. We used 1 milligram of semaglutide. They lost 4.5% of body weight. They went from a mean of 90 to 85 kilos. These people are not wasting away. And we see a 25% reduction in fat around the kidney, 13% reduction within the kidney. That's 3 to 5 times as much fat loss as was body weight loss. There's a reduction in renal arterial resistance. And this measure of cortical ADC, diffusion coefficient, is a measure of fibrosis. We see progressive fibrosis in the placebo group where it is attenuated or actually stopped in the intervention group. Now, for those of you who love blood vessels, this is actually from a paper we just presented at the World Congress of Nephrology, coming to you soon in a major journal. Here's the effect on the periglomerular arterioles. This is before semaglutide, after semaglutide. This is a significant by morphometric measurements, reduction of some 30% in thickness of the vasculature. And again, here are our periglomerular immune cells that are markedly reduced. It looked almost exactly like the models would have predicted. And now I'm just going to give you, again, a very brief insight into what we learned about what was happening at the cellular transcriptome. So this is what we call a cell map, a hub map. This comes from our work in the Kidney Precision Medicine Project. We've actually identified new cell types that were not known even 5 years ago. But suffice it to say that all 31 canonical cell clusters were identified, meaning high-quality tissue, and we had 800,000 nuclei that underwent transcriptomic assessment. The most modified cell is the endothelial cell. The glomerular endothelial cell, we now know from KPMP, there are at least 2 distinct endothelial cell populations, but also regulated were natural killer T cells and the proximal tubule cell even though to a lesser amount, it's just sort of eclipsed by the effect of the endothelial cells. Again, high-level view, 63% of the genes that were regulated are in metabolic stress pathways. So back to your talk, Rodica, they improved oxidative phosphorylation, improved markers of mitochondrial function, and reduced glycolysis. And then 60% of fibroinflammatory genes were downregulated. There are a number of them, but many of them are the NF-kappa B, and TGF-beta pathways, as well as things that regulate MAP kinase signaling. And now I'm going to show you a picture to wrap it up because they paint 1,000 words. This is now the spatial transcriptomics. Here I'm going to focus on two cell types, the endothelial cells and the natural killer T cells. So here are endothelial cells represented in red, and they're natural killer T cells, again, replicating what we saw in the models, periglomerular inflammation. And after 1 year of randomized treatment, this is slightly different magnification. We see stability of the endothelial compartment, but basically an extinguishing of the invasion by natural killer T cells. So the way we put this together is that our view of how semaglutide works on the kidney, and by the way, yes, we've done mediation analysis. No more than 10% of this can be attributed to either change in glucose or body weight. These are direct effects on the kidney. Reduce perirenal and intrarenal fat, improve glomerular hemodynamics. At the endothelial level, this is where the main transcriptional reprogramming occurs. There's improved metabolic and fibroinflammatory signaling, reduces the endothelial stress at the filtration barrier, so better microvascular function, stabilized fibrosis, read out clinically, reduced albuminuria, and we no longer say slow GFR, we say preserved glomerular filtration rate. So here are my questions. I'm going to go back to the clinical stuff, but I think I've shown you that I think these agents are probably likely to work on other blood vessels like they do in these blood vessels. You probably won't have biopsies of other organs like this, so I think it's really a landmark observation what we're going to be able to report to you. But here are my clinical questions. Back to the work from Best CLI. Do antiplatelet agents protect against MALE in people with critical limb ischemia and advanced CKD? And is it safe? Where will the safety profile land, especially risk of bleeding in this population? Do GLP-1 agonists reduce risk of MALE in the high-risk population with type 2 diabetes and CKD? Again, you'll hear more about STRIDE, but I've given you a little tidbit from Flow. And might the treatment effects vary by GFR or UACR? And I would submit that we probably get more benefit at lower GFR. Higher-risk patients have the most to gain. And can MALE risk be averted in people with kidney failure treated by dialysis or transplant? Would we try antiplatelet agents, GLP-1 agonists, and are they safe in this population? And I do want to call this group out because they're a vulnerable group of people and have largely been overlooked in these trials. So with that, I say thank you and look forward to your comments and questions.
Thank you, Kathy. Those were two incredibly provocative and informative talks, and I'm sure there's going to be a lot of questions. I have a ton of questions, but I'm going to start out with just one or two that apply, for both of you. One is the general question about dosing. It seems, in some ways, a little arbitrary. So both dosing in terms of amount, but also duration of therapy, and what biomarkers should we be using? I mean, a lot of it seems to be driven around looking at either A1C or weight. But how exactly would we think about dosing from the standpoint of the vascular outcomes? So that's one generic question. And the other generic question I want to ask you is about the intersection of hypertension, which hasn't been brought up at all here. But is it a modifier, potentially, of the beneficial impact of these drugs? How is it is it controlled in these trials in such a way that's able to be duplicated in the real world? I mean, can you talk a little bit about the intersection of hypertension as a modifier potentially of these treatments? So I'll start with that.
Yeah, great question, Mike. Thank you so much. Regarding dosing, I assume that you are talking about perhaps GLP-1 receptor agonist because they have obviously made the center stage today. And I'm just going to say that yes, it's important, but it's also dependent on the patient population that it's targeted in that particular trial. So obviously the dosing, for instance, in SELECT that you have shown, it's different than the dose that we have tested in SOL or FLOW. And there are different patient populations for that reason. The mediation effect is also very interesting because because you talk about biomarkers, right? So to try to understand biomarkers, we need to understand what's driving that particularly effect on this vascular outcome. And I know that I'm sure Mark has done that in STRIDE. We did that in SOL, and it was done, and we did it in SELECT as well. What mediates the effect is not necessarily the weight reduction nor the glucose reduction, although in SOL at least the glucose lowering had a much higher impact in mediating the effect on both the primary MACE as well as heart failure, much more so than weight, which was surprising to us. But what was actually the driving force which was unified was the effect on inflammation. And I alluded that through my short talk that what was consistent, at least across all GLP-1 receptor agonist trial, which was first confirmed, in fact, in basic model at the bench, was this consistent reduction in marker of inflammation, and in this case, hsCRP. And the drop is dramatic, and it happens very early, and it's sustained throughout the trial. So I think that that's one of the components that we can target, how to find inflammatory biomarkers that can guide us how to select the best dose. So that's my take on that.
Yeah, I actually think that the dose effects are important. Now, again, I'm going to give you the nephrocentric view, but you don't have to lose weight or have a change in glucose to get profound target organ protection. That said, you know, in some of the studies now that are reading out for obesity and CKD, we don't have outcomes data, but we have albuminuria data, which is a very good biomarker of response. You get an even larger albuminuria reduction when there's weight loss with a higher dose. So I think it's and both. I think the risk factors benefit these target organs, so losing weight, lowering glucose, lowering blood pressure, but then there are direct target organ effects, because we've done these experiments before. You don't get this kind of protection with bariatric surgery or conventional glucose lowering or blood pressure lowering therapies. But both are important, and I think that's the magic of it. So if you need to give a higher dose for weight or glycemic indications, great, and then you get the target organ protection. But again, we go back to the CKD population. There are times where we don't want them to lose weight, right? Especially when GFR gets down below 30. That actually can be a safety issue with sarcopenia and wasting, which is already happening because of chronic kidney disease. But then again, don't avoid the agents. Use the non-weight loss dose in those agents. And then as far as a readout, I agree with you on the hsCRP. And again, now, at least in the kidney, and I think it's a great window into the circulation, we're going to be showing you many of the pathways that are modulated. The really interesting thing, though, is that, and again, we've presented this at a meeting, so I can say this, is that the systemic biomarkers do not reflect what's happening at the tissue reliably. So again, I think that albuminuria is also a great readout. And even if you're not looking at CKD populations, even within the normal range, we know there's a linear relationship, actually exponential, between albuminuria and cardiovascular outcomes. So I would encourage you, and the new PREVENT equation includes albuminuria and GFR, is to look beyond conventional risk factors and look at the urine too. And I don't think it's one thing. I think it's, look at hsCRP, look at albuminuria. These are really good readouts, and albuminuria is a great marker of endothelial function, of what's happening in these target organs. So I'll stop there.
May I?
So just back to dose, one more thing, because you didn't touch on the duration, but are we talking about lifelong therapies for everybody? Because this is also a big issue in conversations with patients. So especially if we're going to, let's say we're thinking about expanding this to, I don't know, I have a patient with PAD who does not have diagnosed type 2 diabetes, but they're a little overweight. Are we talking about in all these cases that these would be lifelong therapies? Is there any evidence that you can have reversal of some of the epigenetic things that we're talking about here with treatments that are not lifelong, or are these required to be sort of chronic long-term therapies?
Well, we haven't studied them that way, right? But, again, if we look at some of the readouts, I'll go back to albuminuria. If you stop the drugs, it goes back up. So I think it's going to end up, at least based on the way we understand and treat people now, it's going to be like hypertension and like diabetes. I don't think that we've really cured the problem. I think that there can be restoration of organ function, but I think it's going to require ongoing maintenance. Now, the question could be, though, after somebody loses weight, can you use a lower dose? We've also thought about, can you treat people intermittently based on readouts like hsCRP and albuminuria? But I think that's future research. Maybe that's something this group could look into.
Go ahead, Rodica.
Yeah, I'd just like to say the same thing. Kathy took my words.
Oh, sorry.
That's exactly what we are doing. We are now testing whether once you reach a certain target, you can either treat with a maintenance dose or intermittent therapy. So that's something that is being actively tested as we speak. I like to, echo what Kathy said regarding microalbuminuria, because I think arguably that's an even better CVD biomarker than even kidney biomarker by itself, and that has been known for many years. And completely agree that yes, systemic inflammatory markers are not as sensitive and specific, but we are also now at a time in which we can take the lessons from flow, for instance, from this important transcriptomic analysis that can enable us to understand which pathway is most likely to be activated in a given organ, in line with what I also said, and then convert to biomarkers that are actually readily accessible at the point of care. Let's take the NT-proBNP, and that's another very important success story, because we are now able to apply a biomarker with a very high sensitivity of specificity for asymptomatic disease that can be actually ordered at the point of care, and it's affordable and gives us important information. And heart failure is a huge healthcare problem, and it is now, in fact, the most prevalent cardiovascular complication in diabetes, just to talk like that. So we do have now an opportunity to translate the finding from this super expensive and complicated analysis, and also invasive, because, the reality is that, I've been part of the Pearl trial. I've been working with Matthias Kretzler, who was an investigator on a portion of the patients for remodel. And actually, people with diabetes these days, maybe some want to have a kidney biopsy, but majority actually are reluctant because they know that they may not necessarily need that invasive procedure. So let's take that knowledge that we've learned from flow and then translate it in identifying biomarkers that can be applied easily and much more accessibly to all people with diabetes, for instance, and vascular disease.
I'm sure there's questions. There's a microphone on the floor somewhere. There must be some questions from the group.
And while they're coming up, we should talk about hypertension, which was your question.
Yeah.
That's really important. I think I don't want to miss that. And we know also from work of the AHA and others that hypertension control is also was getting better and now getting worse again when you look at the population level. And it's one of the most important modifiable risk factors for this whole portfolio of complications that we're talking about. And so I think that everything we're saying about organ protection is layered upon good risk factor control, whether that's lipids, glycemia, blood pressure. But blood pressure, really is something that should be achievable. We have effective medicines, but we also need better attention, surveillance, and intervention. So to me, that's foundational, and then all these other things are layered on top. So I think attention to public health strategies to improve identification and management of blood pressure is essential to total cardiovascular, kidney, metabolic health. There's a reason K is in the middle, right?
Dave.
Rodica, great talk, and Kathy as well. Rodica, I know you've done a lot of great work on diabetic peripheral neuropathy over the years. Where does this fit into that, and who should be started on it, and where does that potentially lead us towards? and as well as retinopathy too.
Well, thank you so much for bringing that up. Yes, it's true. And neuropathy, it's a huge, component in this entire vascular risk, because what is also very important, and perhaps it wasn't alluded yet too much, I know there is a talk later today, because in diabetes, it's not just the large vessel, it's in fact the microvascular dysfunction, which plays a phenomenal important role. And this dysfunction in the microvasculature affects the heart, affects the kidney, affects the nerves. And in fact, in the nerves, they control as well the heart function through the autonomic component. And again, it was not the focus today, but I could talk a lot about how the autonomic dysfunction involves both the heart and the kidney, as a matter of fact, and they are intertwined and interlinked. Neuropathy, in fact, one of the main targets, as it's true for any type of vascular complication, inflammation, it's at the center. And I'm actually very happy to tell you that, although it's not so well known, we do have now a phase 2 trial with one of the GLP-1 receptor agonists targeting neuropathy. And hopefully that will continue, but I cannot say more because the trial is ongoing. And thank you for this question.
Manesh.
Hey, really great. And I guess one of the questions for CKD, for many years at Tuttle, it's a great cardiovascular risk marker. In fact, you would say, since you need, often you can imagine patients, GFR is affected by their blood pressure, their diabetes, their cholesterol, their weight, a lot of it captures in one measure. Is there a place that's not specific to GLP-1? Because for other therapies, we were always struck by what's modifiable. There's a percentage of patients, not the ones in flow, that have CKD at a certain stage. We know in Medicare, for example, unfortunately 20% of people on dialysis pass away in the next 12 to 18 months, often from cardiovascular causes. But the modifiability of that, it's hard to know. Not to say we're not caring for them, I'm just thinking about that from the perspective of how do we apply the right therapies along this spectrum of, let's say, GFR 50 to 70, 50 to 25.
No, those are really important. They're public health questions, really, Manesh, because in my view, if we had better awareness around CKD detection and intervention, 3/4 of it's diabetes and hypertension, half diabetes, 25% hypertension. If we identified and managed people with diabetes and hypertension properly, kidney failure should be a very rare outcome. But let's go to the current state where it's not a rare outcome. I think those are important questions, but it gets this issue of renalism. I mean, do you just give up on these people? I mean, and actually, again, I'm going to go back to the specific data from the USRDS. If you have type 2 diabetes and you end up on dialysis, you have a 50% chance of being dead at 2 years. There aren't many things more fatal than that, except really bad aggressive cancers. But we don't give up on other people with those kind of mortality risks. So, whether or not conventional risk factor control is going to stop that, probably not. We still don't want to have uncontrolled hypertension, that's a way to prevent stroke in the population. But I actually have a slide, and I hit it. I was going to show you data on dialysis patients with GLP-1. So I'll just give you the quick summary. From 3 trials, FLOW, SELECT, and SOUL, we did an analysis of people who stayed on randomized treatment, so sema versus placebo, and went on dialysis. And there were about 600 of them, most of them, of course, from FLOW, but a few from the others. And we said what happened. We were mainly looking at it for safety, but we looked at MACE and all-cause mortality. Again, all the warts and blemishes of a post-randomization, post-hoc analysis. Male, reduced 20%, all-cause mortality, 20%. Now, you can argue that that was a survivor bias or something like that. But, first off, we were worried about whether or not we were hurting people. Then there's also a real-world analysis of the U.S. renal data system data set. So now, you're talking about tens of thousands of people on dialysis treated with GLP-1s. Mortality reduced 20%. And for those of you who are surgeons and might live in transplant world, 80% higher chance of being listed for transplant if you received a GLP-1. And if anything's going to save you from that fate, it's a kidney transplant. So I would say that those sources of evidence are not definitive, but I think that points us in the direction that we do need to try to do something for people. That's why I put up specifically GLP-1s. But our data from BEST CLI made me wonder about withdrawing antiplatelet agents in these people too. So I think we need a trial. Will we have the fortitude to do one? I think that remains open.
We have time for one more. Yeah.
Just a small question, I guess. I didn't notice any specific different type of GLP-1 RA that was used. I wonder if you can comment on that, if some classes might be more efficacious over others and preferable, or to be avoided.
I guess that GLP-1 receptor agonists have several drugs, right? It seems to be a pretty consistent effect across several of these agents, although not all. So definitely we do have strong evidence with a shorter acting like liraglutide. Dulaglutide, it's longer acting, semaglutide are the one that have the strongest level of evidence. And now that we have, of course, the dual GLP and GIP, which is a different type of medication in a way, which is obviously acquiring emerging evidence for cardiovascular risk reduction and protection. I like to make just one small comment because earlier this morning Manesh mentioned combination therapy. And the fact that now we actually have very strong evidence that combining these two most promising classes, which are the SGLT and the GLP-1 receptor agonists, are not only safe, but they're efficacious. Before, there was some concern that in people who have higher cardiovascular risk and are treated with both SGLT2 and GLP-1, that may not be necessarily a safe opportunity. But we were able, and although, obviously no industry is going to do this type of head-to-head and combination trial, we do have a huge amount of data from SOL. SOL was the latest GLP-1 receptor agonist trial that was done, and in SOL we had at baseline about 30% of people who were treated with an SGLT2 inhibitor, and during the trial, that proportion went up to almost 50%, demonstrating not only the safety of this combination, but also continuous benefit. So I think that that's another important lesson that we can capitalize on.
All right, thank you both. That was a wonderful session.